All right, so this presentation is on the principles of aerobic exercise and cardiac rehabilitation. We went over aerobic exercise last semester in Therex 1, so a lot of these definitions and concepts should be a review for you. We also touched on cardiac rehabilitation briefly last semester, but we'll certainly go into a lot more depth today. Here are the objectives for the lecture. All right. Here is the old values and new values for diagnosing hypertension. So the new values, as you can see, have a lower threshold for diagnosing someone with stage 1 and stage 2 hypertension, or being in stage 1 or stage 2 of hypertension, as opposed to the old values where as long as you're 139 or below, you are still in the pre-hypertensive state. Now, just being above 129, so at 130, you'll be considered stage 1 hypertension. And then you can also see stage 2 also has a lower threshold in the new values. All right, so we're going to go over the following terms or definitions as it relates to aerobic exercise. All right, so first definition is physical fitness. So physical fitness is kind of a general term, but is determined by all of the components you see below. So it's determined by cardiorespiratory function, muscular strength, endurance, and flexibility. And all of these components determine one's physical fitness. All right, so maximum oxygen consumption, or VO2 max, is the body's capacity to utilize oxygen. So it's the max oxygen per minute at max effort. This is determined or dependent on the transport of oxygen, oxygen binding capacity to the blood, cardiac function, oxygen extraction capabilities, and muscular oxidative potential. So all of these factors will determine someone's VO2 max. Also important to note that maximum oxygen consumption is influenced by the following additional factors. Those include age. So generally the lower your age, the higher your VO2 max. And then as you get older, that tends to lower. Gender, males in general have a slightly higher VO2 max, although it's very dependent on proportion of lean body mass. Heredity is another factor, as well as inactivity and disease. Next term we'll go over is endurance. So the ability to work for prolonged periods of time and the ability to resist fatigue is a more general definition of endurance. But you have specific types of endurance. So you have muscular endurance. So the ability of an isolated muscle group to perform repeated contractions over a period of time. You also have cardiovascular endurance, so the ability to perform large muscle dynamic exercise for long periods of time. If the plan of care instructs you to work on improving a patient's endurance, you need to know what type of endurance the plan is referring to, as these are potentially very different goals. All right, aerobic exercise training or conditioning is essentially augmentation or improvement or enhancement of the energy utilization of muscle by means of an exercise program. Training is dependent on exercise of sufficient frequency, intensity, and time. it produces cardiovascular and muscular adaptation and is dependent on the specificity principle. So as a reminder, specificity principle is essentially that adaptations you see with conditioning are specific to the type or mode of exercise being done. Again, adaptation is changes in the cardiovascular system and muscles due to training stimulus over time, and this results in increased efficiency, and you have essentially improvement in performance at lower physiological expenditures. So this is key. Performance can improve and at lower energy levels. All right, myocardial oxygen consumption, as opposed to max oxygen consumption. Myocardial oxygen consumption refers to the measure of oxygen consumed by the muscles of the heart, or the myocardium. This is determined by heart rate, blood pressure, myocardial contractility, and afterload. Afterload is the ventricular force required to push blood through the aortic valve at the beginning of systole. So, for example, a younger person whose max heart rate is, let's say, 200 beats per minute, they're going to have a higher absolute value that they can achieve with their max myocardial oxygen consumption compared to someone who is older, who has a lower max heart rate. So that's one way heart rate can affect myocardial oxygen consumption. Deconditioning. Deconditioning can either be acute deconditioning or chronic deconditioning. So you can have someone who has very sedentary, who over long periods of time have become deconditioned, or someone who had an acute injury and has just been had a period of prolonged bed rest following that injury, and they can get very deconditioned, or they can get deconditioned very quickly following that. This results in decreased maximum oxygen consumption, cardiac output, and muscular strength. All right, so the two YouTube links you see below provide good reviews of the circulatory system, so good kind of anatomy and physiology review for you. So please pause the video, take a couple minutes to watch each one, and then resume. All right, so next we're going to talk about cardiac output. Cardiac output is a product of your stroke volume and your heart rate. So stroke volume is the amount of blood pumped out of the ventricles with each contraction, and cardiac output is the volume of blood pumped from a ventricular of the heart per unit of time. So if the stroke volume, let's say, is 50 liters, and you multiply, and you have, let's say, a heart rate of 60 beats per minute, if you are able to keep that stroke volume the same at the same 60 liters and increase the heart rate, that will increase the total cardiac output. So if stroke volume stays the same and you increase heart rate, obviously cardiac output increases. Same thing occurs, you can potentially increase cardiac output by having heart rate stay the same but increasing stroke volume. So they essentially, if one increases, then cardiac output increases, assuming the other stays the same. All right, so cardiac output is the heart's primary function. It allows for adequate it essentially dictates whether or not the body's metabolic needs are met. All right, so if the cardiac output is sufficient enough it has to meet some threshold, and assuming it meets that threshold, the patient's metabolic needs, the oxygen needs of the tissues are met. All right, so we're going to go over some different diagnoses specific to cardiac function and different physical therapy interventions. So some specific cardiac diagnoses that we'll go over is coronary artery disease, atherosclerosis, angina, myocardial infarction, heart failure, heart transplant, and pacemaker, and AICD. All right, so we'll go over each one of those in detail. So first one, coronary artery disease, or CAD. Essentially, you have atherosclerosis of coronary arteries leads to ischemia of the myocardium. All right, you have both modifiable and non-modifiable risk factors for coronary artery disease. As a summary, modifiable risk factors are risk factors that the patient can change. So these are the ways that we as clinicians can hopefully impact or prevent someone from developing coronary artery disease. So we can't do anything to change someone's age, sex, race, or family history, but we can hopefully have an impact on their smoking, high blood pressure, elevated cholesterol, obesity, inactivity, and stress. So it's important to educate the patient on how these modifiable risk factors can increase the risk of developing coronary artery disease. All right, so you want to educate the patients or your patients on the importance of smoking cessation and eating diets that are low in cholesterol. General exercise, so just encouraging the patients to stay active can help with obesity and obviously inactivity. And then you can do potentially encourage the patient to use stress reduction strategies to help manage their stress and lower their blood pressure. All right. Next, we'll talk about angina. Angina is essentially cardiac-related chest pain secondary to ischemia. Essentially, blood supply of the myocardium cannot keep up with demand. Blood supply to the myocardium cannot keep up with demand. With stable angina, you essentially have chest pain that occurs during exercise, whereas unstable angina, you have chest pain that occurs just at rest. This unstable angina is referred to as pre-infarction angina, and this is a medical emergency. All right. Myocardial infarction, or MI, is kind of essentially the medical term for a heart attack. So myocardial infarction, we essentially have myocardial cell death following complete occlusion of a coronary artery. Whereas angina, you just have ischemia to the myocardium. With a myocardial infarction, you have complete occlusion of a coronary artery. Generally, a plaque will rupture, resulting in a thrombus or blockage further down the system. All right, next we'll talk about heart failure. Heart failure, or congestive heart failure, CHF, is a chronic progressive condition that occurs when the ventricles can't pump enough blood